Good morning, good afternoon, and good evening. Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Ramana Naidu from California Orthopedics and Spine, California, United States. Dr. Naidu is an anesthesiologist and pain physician and the medical director of pain management at the Marin Health Medical Center and the medical director of Marin Specialty Surgery Center at California, United States. Dr. Naidu is primarily based at the California Orthopedics and Spine Group. As a neuromodulator, he's an expert on spinal cord stimulation, dorsal root ganglion stimulation, and peripheral nerve stimulation. Dr. Naidu earned a medical degree at the University of Wisconsin School of Medicine and Public Health in Madison, where he was born and raised. He completed residency in anesthesiology at the University of Washington at Seattle, followed by a fellowship in pain management at the University of California and San Francisco, California, United States. And he continued to be assistant professor there for a period of 5 years. He was a Fulbright scholar in public health in Denmark with the WHO Regional Office for Europe. Dr. Naidu is a member of several professional organizations, including the American Society of Anesthesiologists, California Society of Anesthesiologists, and American Society of Regional Anesthesia and Pain Medicine. So today, it's my great honor to introduce you to Dr. Ramana Naidu from California Orthopedics and Spine, California, United States. Over to you, Rama.
Thank you so much, Hitesh. Thank you for that introduction. That was very nice. I'm very honored to be here speaking to all of you. As you heard, I'm an anesthesiologist, so I'm an outsider from the orthopedics world, but very much an insider in that I collaborate with the orthopedic group that I work with, and I help a lot of the patients that may continue to suffer from chronic pain, whether from trauma or from surgery. And certainly when patients develop chronic pain after those issues, and you as surgeons do all the right things to correct the mechanical failures, they may go on to have pain, and it's not your fault. There may be issues with the nerves or the patient's genetics that result in chronic pain. So why I'm here today is to talk to you about some of the new technologies that are emerging in peripheral nerve stimulation, which is a unique way of modulating the nerve to stop or at least alter the way that nociceptive or painful signals are going from the periphery through the spinal cord into the brain. So I have several disclosures, and that is because I like to work with a lot of different companies on some of these newer technologies. When I was a fellow at the University of California, San Francisco, UCSF, I realized that if we were going to continue to use opioid medications and steroids for pain management, we were not going to go very far. And so what I grabbed onto were some of these emerging technologies at that time with neurostimulation, such as spinal cord stimulation. And at that time, it was okay, it was pretty good, but I saw the future in a way. I thought that, hey, there was a lot of investment here, and we knew that opioids and steroids weren't going to be the answer. And sure enough, as you all know, the United States went through its opioid epidemic, and certainly we've learned a lot from that. But from day one, I was saying opioids were not going to work. So I'm sort of glad the country has caught up to that notion, because as we all know, there are a lot of risks to those medications. And if we look at the use of opioids in pretty much every other country besides maybe Canada and Australia, there really is hardly much use. And really, you know, there's a balance to it. There's certainly situations where we need those medications, i.e. end-of-life care, cancer, pain. But there are certainly situations where they may be overused, as in surgery or in trauma, and that can lead to consequences such as opioid-induced hyperalgesia, let alone the issues with addiction and respiratory depression. So I'm proud to work with all of these companies. You're going to hear about some of their technologies through this talk, but I try to remain as balanced as possible and give you a spectrum of the entire field of peripheral nerve stimulation. So neuromodulation, if you're not familiar with this word, we actually have a journal as part of the International Neuromodulation Society, and in which we are trying to look at how do we alter the way that nerves signal. And obviously here we're talking about pain, but nerves can do a lot of things, as we all know. They can be involved in motor function. They can be involved in vasomotor action, i.e. the vascular system. They can actually be involved in how the gut works and how our autoimmune systems and endocrinological systems work. So the future is very bright in how we place electricity near these specific nerves to alter the human disease state. So then the question is, how do I modulate that nerve? And I'll show you all the ways we have been doing it for years, and some of the things that you're very used to, you might not even think about it as neuromodulatory, but in essence, they are. Then the next question is it sustainable? Do these therapies last for a long enough period of time, or do they wear off and then the patient is right back to where they were? Next question is it comfortable? Because a lot of these therapies, you have to weigh the risks and benefits of how invasive they are, how much of a bulk there is as far as the battery, for example, or the leads. So that's a very important question. You can make an amazing technology, but if it's not comfortable for the patient, they're never going to buy into it. And then last but certainly not least, is it economical? In the United States, we have a mix of private payers and government payers. All of them are looking at what is the cost effectiveness of these therapies. And certainly in India and all parts of the world, we have to look at these technologies and their costs. They're not cheap. We certainly respect the amount of research and development that has gone into the development of these technologies, but we can't impose that on our government payers and on our patients and expect them, to give up, half their life savings or whatever else just to have these therapies. But as we all know, as we scale therapies, costs go down, manufacturing improves, and so we're very early in this development to get to that point, but that is certainly something I think about, and I think a lot of the companies think about as well. So here are all the methods of neuromodulation. As I mentioned, a lot of these things are something you're very familiar with, such as local anesthetics, lidocaine, bupivacaine, mepivacaine. All these canes have been neuromodulatory for years, going back 140 years to August Speer in Germany, and then coming over to all different parts of the world. Local anesthetics, as you know, are limited by the duration of effect, and usually that's limited to several hours. And what that results in is a neuropraxia for a transient period of time that then wears off due to redistribution, and then the patient feels their nerves and everything else again. And so these are great things for acute episodes, such as in surgery, so that we use it in regional anesthesia or for local anesthesia and eyeball, the spine, local wound infiltration for all the surgeries we do. But again, their effect is transient. If you look at another chemical way of addressing those nerves, phenol and alcohol, that can result in long-term duration of relief. However, there is irreversible damage a lot of that time, and that leads to a second or third degree sediment classification that results in exonemesis. So the structure remains intact, but the endoneurium starts to become denatured. The next modality is radiofrequency ablation, which you may be familiar with. This is where we actually create a thermal lesion around a needle tip adjacent to a nerve that we place either fluoroscopically or via ultrasound. Radiofrequency ablation does cause a destructive lesion, and it does increase the amount of nerve damage for the sediment classification. One can get several months of relief after these procedures, whether for the medial branches of the lumbar or cervical spine, or for major joints such as the knee, the shoulder, the hip. And if it comes back, 6 months or 12 months later, the pain that is, you can have a repeat of this procedure. Another option, which is in the United States kind of come and gone, is cryoneurolysis. That's basically freezing the nerve. Again, creating a different type of Wallerian degeneration of the nerve to help reduce pain signaling. And the reason it's sort of come and gone and maybe trying to come back again is that the duration of relief isn't quite as long as what we see with radiofrequency ablation, so that's the head-to-head battle. And then last, certainly not least, is electrical stimulation. And a major reason why I really, I don't want to say focus, but why I'm really intrigued by this therapy is that it should not alter the function or the structure of the nerve. So we can actually modulate the nerve without causing any mechanical or physical damage to it. And that's why it's very interesting. You turn off the electrical stimulation and that nerve is just functioning as it was. So you have that reversibility to play with. Now, there's been a lot of confusion about peripheral electrical stimulation. There are a lot of different types of ways we provide energy to an area, a focal area of the body. So with peripheral neurostimulation, which I'm going to talk about to you in detail today, that is specifically placing an electrode array next to a specific nerve. There are other forms of stimulation, as you'll see below. Peripheral nerve field stimulation, that's basically placing the electrode array in the low back or around the thigh or in the knee. It's not targeting a specific nerve. It's not localizing a specific nerve. It's just placing an array there. And the hope is that that field of electricity will capture maybe the nerves or the muscles or whatever targets to get that area of pain. We do not want to confuse these two. I always teach fellows and residents that when it comes to PNS, you must name the nerve and you must identify it under a visualization approach in order to ensure that you are going to get therapy at that specific nerve. We cannot be loose or sloppy with placing leads wherever we want and expecting a good result. Percutaneous electrical nerve stimulation, or PENS, that's when tiny electrodes are basically inserted into the skin. So almost imagine like a Velcro-like material you can squeeze in with tiny needles, and that can create electrical stimulation. So it's getting deeper than the skin. Then there's percutaneous neuromodulation therapy. These are longer filaments that are placed deep into the tissue. And then last but certainly not least, transcutaneous electrical nerve stimulation, or TENS. And this is when we put electrodes on the skin and we hope to penetrate through the skin, which has high resistance, and get to a nerve or an area of pain. Now, TENS has been around for a very long time, 150 years. Here's an example of the Guyfit TENS from 1871 out of Paris, in which you can see these different instruments here on the right-hand side of this picture that can place it in different areas like the ear, the temple, the joint. They had different ways of providing the electrical stimulation. And then, of course, they used their electrical lights in these bins and connected wires, and then, of course, used mechanical spin to create the charge, and then applied that to the patient. Here, 100 years ago in the United States, this was one company, the Electrete, as you can see here on the right. You can see the electrodes, not too different than what you see today. And basically, you roll that to develop the charge in that cylinder, and then that provides the static converted electricity to the electrodes to the patient, and you basically place that on the patient's area of pain. And I love the statement at the bottom as far as their marketing. Two things cannot occupy the same space at the same time. You shoot in the electricity to shoot the pain out. And so that's 100 years ago. And I think in some ways we might think that may be true today. However, we have become much more sophisticated in how we address electrical stimulation on the nerve. Then in 1967, this marquee paper from Norm Shealy, neurosurgeon out of Wisconsin, which is actually my home state in the United States here, he published this paper on electrical inhibition of pain on the dorsal columns. I actually placed an electrode directly onto the spinal cord. And this was the birth of spinal cord stimulation. Now, what's interesting in this article is that if you look at this paragraph in the lower left, this was the introduction paragraph to this article. And he mentions the role of peripheral nerve stimulation that was done by Doctors Wall and Sweet, Pat Wall, and the neurosurgeon Dr. Sweet, and suggested that yes, peripheral nerve stimulation does work with these parameters. And then in Dr. Shealy's experience, by doing it on the peroneal nerve, he saw no impact there, and then made this pretty concrete statement, which might have hurt the entire field of peripheral nerve stimulation for decades, in saying this emphasizes the impracticality of peripheral nerve stimulation for relief of diffuse pain. Now, he was correct. It wasn't a very good way of dealing with diffuse pain. Spinal cord stimulation is very good for that because you can cover the entire trunk or an entire limb. Peripheral nerve stimulation is very good for focal pain. But this statement, using the word impracticality and peripheral nerve stimulation, I think made people think that maybe we should be moving away from peripheral nerve stimulation and focus on spinal cord stimulation, which we certainly did in the industry since from the 1970s on. Now, in 1984, we saw some animal work, which really did prove that, from an electrophysiological standpoint, peripheral nerve stimulation does have a role in nociception. And you can see here in this graph, using a rat model, that there was inhibition with peripheral nerve stimulation of the spinal thalamic tract when that rat was exposed to noxious stimulation. So there truly is some effect, and I can certainly tell you that in my own experience, peripheral nerve stimulation can absolutely alter the nerves. Now, from the 1960s, as you saw from Wall and Sweet, through the 1990s, peripheral nerve stimulation was primarily a neurosurgical procedure. What we did is we used those large electrodes you saw from Dr. Shealy in the spinal cord, and we just placed those in the periphery and tunneled that to a battery, maybe in the chest or the flank. And so the leads had to cross over joint lines. And this was, again, an open surgical procedure. So what's changed in the last 20 years? Several things as far as technology. Number one, ultrasound. So now we can visualize nerves, vasculature. We can see where our needles are being placed. Our peripheral nerve stimulation lead design has improved significantly. So no longer do we have those large paddles with 4 electrodes. We have super tiny leads. I'll show you in just a bit from some of the companies. Our energy transfer designs have basically come around full circle. In the 1960s, energy transfer designs really involved radio frequency from outside the skin across the tissue to the actual lead. It was a wireless system way back then. And then we started to develop the implantable pulse generator in the 1980s, and we started implanting these under the skin. Well, today, in the 2020s, we're back to that wireless design where we have an external power generator transmitting a signal, whether through radio frequency or Bluetooth, to the lead to then cause the stimulation. And I'll show you some of those designs in just a bit. And then here in the United States, frankly, it's somewhat capitalistic, as you all know, because the reimbursement models have changed for peripheral nerve stimulation. There's actually somewhat more incentivization to do it here in the last 4 to 5 years than there was, say, 10 to 15 years ago. And the reason for that incentivization is because of the investment in these therapies, more minimally invasive, safer, and the evidence is starting to build. Now, we're still way behind in getting to those really nice level 1 randomized controlled trials to a sham or placebo in peripheral nerve stimulation, but we are certainly getting there. So the anatomical interface between the nerve and our leads is as follows. Now, a nerve is, as you know, filled with different types of nerve fibers. And the breakdown here is on the left, A alpha, beta, gamma, delta, and then the B and C fibers. And when it comes to nociception or pain signaling, we focus on the A delta and C fibers, but these are basically the smallest fibers. And so when we provide electrical stimulation, we're really trying to focus on those fibers and not stimulate or cause any issues, for example, on the A alpha motor fibers, because we don't want to see a motor paresthesia or a patient twitching. We want to only address their pain without affecting their sensation and their motor function. And so that's the nuance here in electrical stimulation. We can certainly just turn up the intensity or the electrical signaling or dosing and cause, a major paresthesia, but that would obviously not be advantageous to the patient. So we have to be pretty finite in the way we stimulate to make sure that we really do what we want to do without causing any untoward effects. And here in the orange are some of the my schematics for lead designs. So this first one on the right with the black and orange, these are the electrodes I was mentioning that were done by Dr. Wall, the neurosurgeon in the 1960s and 70s. I'll show you a design that actually circumferentially surrounds the nerve from one of the companies. And then I'll show you a unique lead design that has a timed anchor that actually we want to be further away from the nerve because it creates a large monopolar field of stimulation. So there are a lot of different lead designs, and we have to think about what that anatomical interface is with those nerve fibers. So in this slide, it's a lot going on here, but the reason I bring it up is the work and the research on mechanism of action is extraordinary. And again, we are in its infancy. So each product has its own form of stimulation, different parameters, distance to nerve, or I call D2N, amplitude, frequency, pulse width, to affect certain nerve fibers and know which locations we are stimulating those nerves, because all nerves are not the same. We have mixed motor and sensory nerves. We have motor-only nerves. We have sensory nerves. We have sympathetic nerves. We have parasympathetic nerves. So we have to know all of those nuances in order to understand how a specific therapy will affect a patient in a certain way. So there's a lot of complexity, and I would say more complexity than what you see even with spinal cord stimulation. And we haven't really begun to determine which forms of stimulation have the best efficacy, longevity, and safety profile. And we have yet to develop a feedback mechanism in peripheral nerve stimulation, which I think is the future. We're seeing that right now with spinal cord stimulation. But can we start to diagnostically look at the function of the nerve based on how it responds to stimulation? And that will be super interesting to basically have, like we've seen in cardiac rhythm management device, a pacemaker that has feedback loops. Well, we can do that for neurostimulation in the periphery as well. And I think that's what we're going to see in the next 10 years. In this next slide, what I want to show you, especially for those of you who are orthopedic surgeons, is this continuum and through the phases of care of surgery. And so as we all know, what we expect here is after, for example, a total knee replacement, patient goes through surgery, they have acute pain and it goes away and they're happy and they're functional and they're loving their knee replacement. They can do all the things they want to do. But unfortunately, for about 10 to 20% of patients, depending on the literature you read, some of those patients go on to develop chronic pain after that surgery. It's not specific to knee replacement. It's 10% of all surgeries, and there's a give and take depending on what specific types of surgery, as we know from Dr. Henrik Kellett's work out of Denmark. But this is no fault of the surgeon, frankly, unless you inadvertently cut right through a nerve. Most of the time, the surgeries look great on imaging, everything went smoothly, but for many different reasons, patients can go on to develop chronic pain. And the mantra has been in anesthesia, hey, if we can knock out the acute pain, really do a good job with it, then that patient shouldn't go on to develop chronic pain. So we use regional anesthesia, we use all these medications, gabapentin, dexamethasone, acetaminophen, NSAIDs if we could, try to reduce opioids because they can actually cause hyperalgesia, which is what we want to avoid. And so we did a really good job when I ran the acute pain service at UCSF in doing that. But what was really interesting is some of those patients still went on to develop chronic pain. They called us a month later, or they would go back to the surgeon 6 weeks later and say, my pain was really well controlled in the hospital. I went home, things were fine. And then things started to return as far as their pain. And so this chronification process, I'm not going to get into all of the details of it today, but it's very, very interesting. It has a lot to do with genetics, anxiety, depression, catastrophization, what anesthesia was used, how the surgery was done. I mean, there's so many factors that play a role, whether it's an indolent infection, et cetera, or repeat trauma. But all those factors play a role in the development of chronic pain. And where we are right now, at least in the United States, is we wait for that patient to develop chronic pain. So 6 months, 12 months, years go by, and then we think about these therapies I'm talking to you about now. But what I'd really like to see is this yellow bar sort of shift towards the left. So can we consider neuromodulation earlier, i.e. the 6-week mark or 10-week mark, when we know that that patient is still having pain, but really shouldn't by now. They should be getting better. Because the earlier we intervene, the better the chances are, frankly, in our experience, that we're going to see improvements. And then going further, could we even think about stimulation prior to surgery? Could we affect the way those nerves are signaling the nociceptive input from the knee replacement so that we could actually eliminate or prevent the risk of chronic pain after surgery? And that's really the holy grail. I mean, that's thinking really long term. I don't know if we're going to get there. There may be factors we cannot alter, but that's really the way we're thinking ahead. So let's go through some of these different technologies. As I mentioned, here's surgical peripheral nerve stimulation, where you actually cut down to the nerve, as you can see here, and replacing an electrode right along the nerve. And as you know, with this lead here, we'll have to tunnel it to that IPG or battery, which is usually in the flank because of the size of it. The issues, though, are scar tissue will develop, people will move, so that lead will move. And in that movement, depending on how it's sutured, it may cause damage to the peripheral nerve. There's an incision, there's a risk of infection. And as I mentioned, when you tunnel to that battery or IPG, you may cross a joint, which may make that person's extremity really unusable because they can feel when they bend the joint, the lead move or the joint actually be restricted in how they can move it, and that can be a problem. Next up is the Neuroscuff electrode. So this is an interesting idea because what the surgical lead you saw here, you're only creating electrical stimulation on one side of the nerve, but we really want to get that entire circumference of the nerve. And so this cuff electrode actually surrounds the nerve. It's a very interesting idea. And they really focused on amputees, so those who went through lower extremity amputation. The challenges here, though, are, again, it's a surgical implantation which can lead to scar tissue development. And once it's surrounding the nerve, if you start to move, the edges of that cuff can start to bury into the nerve depending on how it's oriented. So I haven't seen too much movement out of this company in the last few years, but it's still a very interesting concept, and I'm sure they're refining the technology to reduce those other issues. The next therapy up, and again, this is in no order, I'm just giving you the full spectrum of these therapies, is the Bioness Purple nerve stimulator system. So what we do is we create a small cut down, and we place this small lead that has a receiver that receives the energy from this external pulse generator. And then this lead has tines in it, so it reduces the risk of migration. It basically adheres to the tissue next to the nerve. And this is what the external pulse generator looks like here, this white box that actually puts pads directly over that receiver. And then the patient has a remote to increase the intensity. The programming parameters are fairly basic, but nonetheless, this was one of the first therapies I got into as far as minimally invasive peripheral neurostimulation. This came out about 12 to 15 years ago, and I'll show you one of the studies from it. Up next is the SPR Therapeutic Sprint system. So this is a really small, as you can see, tiny coiled lead. It's placed via a needle, so there's no incision, no cut down. The FDA allowed this to be used for 60 days. The concern here is that the lead hangs out of the skin and connects to this external pulse generator. And so the concern, of course, is infection. But one of the unique things about this lead is that it's coiled, as you can see here on the right. And because it's coiled, it creates its own biofilm, which resists the egress of any pathogens. At least that's what we think. And the proof is that we really have seen, I don't know of any, I don't know if the company knows, we haven't seen any infections other than some maybe local cellulitis, but there really is a limited infection risk with this therapy because the lead is so small and it's coiled. It also provides some elasticity, so when the patient moves, the lead moves with the patient, so you don't cause any tug or migration with it. The next is the Stimwave peripheral neurostimulator system. This uses long field communication. So basically, there's a single external pulse generator that sends a signal to a receiver, which is built in within the lead, and you have different lead designs. This can also be used in spinal cord stimulation. Next up is the Nalu peripheral neurostimulator system. And as you can see here, the implantable pulse generator is about the size of a US dime. So that's really quite small, maybe 1 centimeter in diameter. And then what you do is you place this therapy disc as the external battery source. So you have a small IPG connected to a lead or multiple leads, and then you program or generate the energy from this therapy disc. And you can wear this either with an adhesive clip or you wear a band over it. And what's nice about this is if the patient doesn't want to wear anything, they can take it off whenever they want. The stimulator won't be on. So if they want to use it only at night, they put the disc on. If they want to only use it during the day, they put the disc on. When they take it off, there's no bulky battery inside of them, and there's nothing hanging out. It's all implanted underneath. So this is the latest and greatest of the systems. You can do any form of stimulation with it. So there are different waveforms, which are really advanced, as we've seen in spinal cord stimulation, and this can do that. And this can also be used for spinal cord stimulation. So this has been a fascinating company, and I've been working with them now for 4 years. This is just an example of one of the patients I placed for the deep peroneal nerve. You can see here vaguely in the ultrasound on the right what the lead actually looks like under ultrasound. You can't see the nerve tracks very well, but just where my arrow is where the nerve track is, because I was trying to show you the lead and the nerve, but when the ultrasound waves hit the lead, you can't see the nerve as well. Or if you see the nerve well, you can't see the lead as well. So this is kind of the best picture I could get. It's about 3 millimeters away from the nerve, which is for me the ideal location. You don't want to be directly on the nerve. You want to be just enough with a consistent impedance to provide consistent stimulation. And so this patient did really well after having an ankle and foot surgery. The next therapy is a totally different type of idea. This is specific for low back pain. And the idea here is not to block pain signals. The idea here is actually to cause motor stimulation of the multifidus muscle to strengthen the back, to reduce the dysfunction of the multifidus muscle, which may be the chicken or the egg of low back pain. That's yet to be determined. But this therapy is being commercialized this year in the United States. It does involve an implantable pulse generator, as you can see here, so a battery and a buttock, and then 2 tiny leads that basically go into the multifidus muscle and stimulate the medial branch nerves at around L3. So an interesting concept. I'm sure you'll see more about it at our neuromodulatory meetings in the next several months. And then the last, but certainly not least therapy I'm going to talk about is dorsal root ganglion stimulation. Frankly, this is not a peripheral nerve stimulation therapy, but it's a form of stimulation on the DRG that affects peripheral nerve issues. So that's why I'm talking about it here in this talk. So rather than going to those nerves outside of the spinal cord, we're actually placing the lead in the epidural space out to the DRG. And the DRG is where the cell bodies of the peripheral neurons are housed. And the way the stimulation works, which was originally invented by spinal modulation, is by filtering the T junction of the cell body axon. And it's a pseudo-unipolar T junction, meaning the cell body basically comes off the nerve, the signal goes up and comes down and then goes to the dorsal column. And by filtering those nociceptive signals, we have seen extraordinary outcomes with this particular form of therapy. So this is the only level 1 RCT therapy that I've presented to you here. And it showed phenomenal results where 86% of patients saw at least a 50% reduction in their pain, and more than 20% of patients saw near complete resolution in their pain. Personally, I see this as the highest efficacy of any peripheral nerve therapy, even though, again, this is not peripheral nerve stimulation, this is dorsal root ganglion stimulation. It does involve an implanted system with an IPG, I just did a couple of cases this week where the patients were just mesmerized with the results. This gives you an idea of what I do fluoroscopically. This is probably the most technically challenging procedure I do. What we do is we feed a lead out the neuroforamen, in this case, the L3 DRG on the right side. And then what we do is using a clever sheath delivery system that Abbott has, we create these tension relief loops. So it creates this spring, if you will, within the epidural space. And what that does is it reduces the risk of that lead moving as a patient moves their back. Now, this is affecting the L3 nerve root all the way to that patient's knee. And this was a patient with CRPS of the knee. And you can see here under lateral what it looks like. And we're ensuring that we're on the dorsal root ganglion by looking at the second and third electrodes. So this gives you an idea of what we look for fluoroscopically. This table is a gross comparison of our peripheral nerve stimulator systems that I just talked about. They all have their own bells and whistles, technologies, EPG, and all of those factors play a role in my mind about which therapy I'm going to use for which indication. And so speaking of indications, I'm just going to give you some examples of nerves that we target with some of these systems. So on the left-hand side, I have the named nerves: suprascapular, axillary, femoral, saphenous, sciatic, tibial, ilioinguinal. These are some of the major nerves I work with, but there really isn't a nerve I don't deal with. So if someone has elbow pain, we'll figure out which nerves we're going to intervene on. If someone has post-thoracotomy pain, we'll figure out which nerves we're going to deal with. So these are just the major ones and probably most pertinent to the orthopedic audience here today. As far as those who do chronic shoulder pain, whether after a shoulder arthroplasty or arthroscopy from the rotator cuff, adhesive capsulitis, osteoarthritis, AVNs, tumors, you name it, whatever is causing that chronic shoulder pain, we can intervene on the suprascapular axillary nerves to address that pain. For the knee, we have the femoral, saphenous, and even to some degree the sciatic nerve. Again, after arthroplasty, arthroscopy, arthritis, AVNs, tumors, CRPS, as I just mentioned. So lots of different examples of disease states that may affect someone having a chronic major joint issue. And then going down the list, the sciatic nerve, the largest nerve in diameter, has so many functions. It's a little bit tricky for that reason, where you don't want to cause motor stimulation of untoward areas. For example, if you just want to focus on a specific part of the ankle, you may not want to do the entire sciatic nerve. You may want to just do the tibial nerve, an offshoot of the sciatic nerve. And so that's why I listed here. And then the ilioinguinal nerve, or a groin pain after a hernia repair or inguinal herniorrhaphy. So these are just some examples. I could go on to hundreds of different types of nerves, but I'll just point out these. So these are some diagram schematics of what the suprascapular nerve looks like here on the left, and what the axillary nerve looks like here on the right. I typically use ultrasound for all of my peripheral nerve stimulation procedures. And as you can see here from the spinal glenoid notch here, the ultrasound image from Goldfeld's article in 2018 under neuromodulation, you can visualize the nerve adjacent to the artery. So the suprascapular nerve runs adjacent to the suprascapular artery. And really for all of the nerves we look for, there is typically an adjacent artery. And that helps us visualize because we can see the pulsation, we can use color flow or Doppler to identify the artery, and that helps us clue in on the nerve. So we can see that nerve, and lots of options here. We can run the lead either adjacent, above in the suprascapular fossa, or below in the infrascapular fossa. And for the axillary nerve, we generally place the lead along the surgical neck of the humerus. And that generally gives us a good location. Obviously, the circumflex artery is coming around, so we want to avoid that. And so it's advantageous to use ultrasound to avoid puncturing that artery. For the knee, this is again a schematic of the saphenous nerve, which has lots of different branches. And here you can see on the right from the Tran article, all the variations of the infrapatellar branch of the saphenous. But again, this can be a nerve or the femoral nerve that we target for patients who have chronic knee pain. Here's the evidence in peripheral nerve stimulation, and I'll be very clear. We are still in our infancy with evidence. We have a number of case series, case reports. There have been some failed level 1 RCTs, unfortunately, which haven't shown great results going back 20 years ago. However, the technology has improved, as you've just seen. So I'm looking forward to, and all these companies are really looking at what RCT can we do, what should our study design be, and have a large enough sample size in order to see a therapeutic effect with great safety and great ease of use for the patients. And if you would like to look at all these articles, Dr. Deere and I and others, we did a review of the bioelectronic implications of the stimulation of the peripheral nervous system for chronic pain conditions. This is out of bioelectronic medicine. This goes to a huge overview of all the evidence and all of the things we're looking at when it comes to peripheral nerve stimulation for pain. So, looking at all of those factors that you've seen here, what it comes down to is matching that therapy to the patient. And so what we have to look for is, what is the pain condition? What is the indication? Does the patient have a mononeuropathy? Do they have a polyneuropathy, meaning multiple nerves are affected? Is it sympathetically maintained? Is it only somatosensory? Is it efferent? So we look at all of those things. Then we look at the duration of pain. How long have they been dealing with this pain? And as I showed you from those phases of care, from acute to chronification to chronic pain, where do we intervene? How invasive is the procedure? As you saw, we had those surgical placements of leads, a cuff surgically implanted, all the way to a percutaneous needle lead placement. And then how easy is it for the patient to use the product? They see, some people can't even use a smartphone. How are they gonna, look at this external pulse generator that's creating electrical signal in their body? So it's really important we do a good job making the user interface easy for patients and help them understand that. And then last but not least, patients' preferences. What do they want? Are they willing to have this therapy implanted? What's going to make it easier for them to use it as far as recharging, as far as how much the stimulation is on, when do they use it? All of these factors go through my mind every time I'm talking to a patient about these issues. And sometimes you basically have to deliver what you think is the best option for them. Now, all of these therapies are certainly not risk-free. There are complications, and I want to be super upfront about that. But as you've seen, because we've become more minimally invasive, these complications you might see here have really, really reduced. I have yet to see major issues in my experience. I'm not doing surgical lead implantation or cuff electrode implantation, but everything else I am doing. And so here's some of the issues. There's a lack of benefit, or they have an unpleasant sensation, such as a dysesthesia or motor paresthesia. Migration or tugging movement of that lead, an infection, a nerve injury, a muscle injury can cause bleeding or vascular damage. The leads can fracture, so there can be a hardware issue. They may erode out of the skin, especially for the superficial nerves. And then patients can describe a hypersensitivity. These are low risk or relatively low probabilities. However, I still want to mention them because, again, all of our therapies have a risk-benefit profile. And as I mentioned, we are continuing to improve. The technology is improving. We're looking at the mechanisms of action for all of these different types of therapies, and they're all very different when it comes to deep brain stimulation, spinal cord stimulation, dorsal root ganglion stimulation, and peripheral nerve stimulation. And ultrasound education in that point above is continuing to improve in the United States, and I'm certain it's improving in India because it's becoming basically our stethoscope. It's our way of identifying patients after a trauma, echocardiogram, peripheral nerve injury. And so, as that technology gets cheaper and cheaper and cheaper and cheaper and more portable, we can connect to our iPads or tablets or whatever. I'm expecting the next generation, my children or whoever else, to be using ultrasound to do things just like this and consider using leads or peripheral nerve systems to impact that patient's nociceptive drive. Our biggest onus on us right now in our industry and our field is evidence. We have to do better with that. I'm proud to see level 1 studies in spinal cord stimulation and DRG stimulation, but we just don't have that in peripheral nerve stimulation today in 2021. I hope to by 2030 we'll have that. And where we use PNS will change. As I mentioned, I'm looking forward to seeing if we can start to use this pre-surgically to reduce the risk of chronic pain after surgery. So we're at the 45-minute mark, and I just want to thank again all of you for being with me today, and Hitesh for inviting me to speak to you. I hope this was interesting. And if you have individuals near you that do this, certainly partner with them because they can certainly help you out in your practice. Thank you.
Thank you, Ramo, for that fantastic presentation. A lot of new insight into this new technology. Not really new. Okay, a couple of questions. You mentioned about the indications. I mean, you've covered a lot of them. What about, I mean, you also mentioned about CRPS, the complex regional pain syndrome. And do you think a CRPS1 that the SUDEX would respond to a peripheral nerve or a DRG stimulation?
Great question. So I think that both therapies can work for CRPS type 1. The evidence and my experience would really point to using dorsal root ganglion stimulation. When I was trained on dorsal root ganglion stimulation by some of the Germans and Brits who were using it before we could in the United States, they basically told me this is the cure for CRPS. And I thought, that's crazy. That can't be. This is complex regional pain syndrome. It's complex. It can't be that easy. And they said, no, you will see. And I have seen that. I have seen patients wake up where basically the color, the discoloration, the temperature change, the swelling just goes away. Like it's almost like magic. So dorsal root ganglion stimulation, I would prefer. But look, if someone is fused in the lumbar spine and I can't get to the DRG, then peripheral nerve stimulation can absolutely work. And Dr. Mark Huntoon, who's at Virginia Commonwealth University, he has done a lot of peripheral nerve stimulation for CRPS and has seen a lot of great outcomes.
And do you think a DRG block would be an equally good possibility, or a DRG stimulation?
Yeah, great question. So there are different ways of looking at the DRG and its modulation. So just blocking it, that's basically what we're doing with like a transforaminal or selective nerve root block. And you can see transient effect from that. But really what the interesting in between stimulation and the block is pulse radiofrequency ablation. So there have been some articles on pulsed RF for postherpetic neuralgia and even some of these sympathetically maintained symptoms where they've seen weeks and months of relief. The challenge for us in the United States is that pulse radiofrequency ablation does not get reimbursed. So unfortunately, it's dissuaded people from doing it. But in Europe, as you know, pulse radiofrequency ablation is used ubiquitously. They have a lot of growing evidence. I think it's a great modality. It's safe. I just hope we can use it more in the United States. I think it would be useful. But going beyond that to really give you that long-term relief, DRG stimulation would be the best thing to do.
And have orthopedic surgeons started referring to you earlier because of the opioid epidemic that you mentioned? Do you think they've started referring to you earlier? And what are the common ones that you encounter in your daily practice?
Yeah, absolutely. So there's been a paradigm shift in the last 10 years. And I think especially the younger surgeons are really understanding that if that patient comes back at the 6-week mark and it's not their fault. I think a lot of surgeons historically have felt like my surgery is perfect. It must be in your head that you have pain. So go see your primary, go somewhere else. And that seems harsh, but I've heard that from so many patients. But the surgeons, they're starting to learn, hey, these things can happen. It's not my fault. Let me get you to the right person. And now that I'm part of this orthopedic practice, I think we're creating this new way of looking at these patients. And so now they're starting to send to me at the 6-week mark rather than years later. Because usually what would happen, the surgeon sends the primary sits with them for a few years, and the primary just says, I've had it, send to a pain physician. And then I see them, and I'm sitting there thinking, why didn't I see you years ago? Why now? Why 5 years later? And the patients say the same thing, why now? Why didn't I see you earlier? So we're starting to bridge that gap much better. There was a surgeon I used to work with who would send me all the patients. Basically, if the pain score said 6 or more on the intake form, he would say, go see Naidu, hands down. And some of those patients didn't need anything further, but some of those patients went on to some of these therapies.
Thank you, Ramo, for that. And the other question is regarding spine surgery. I mean, you know that spine surgery has its own issues like failed back syndrome. You do a spine surgery and a lot of patients continue to have pain. Do you see some of those and how do you approach them?
Yeah, great question. So the reason I didn't talk about those patients is because I focus on peripheral nerve stimulation. And typically when the insult to the nerves is happening around the spinal cord, peripheral nerve stimulation will have no effect because you're not in between the site of injury and the brain. So specifically for those, post-laminectomy pain syndrome or post-fusion pain syndrome, we use spinal cord stimulation. And I do a lot of I do way more spinal cord stimulation than I do peripheral nerve stimulation. We have 2 orthopedic surgeons here in our practice. I think you'll hear from Dr. Sue. We also have Dr. Schillingford, but they send patients to me after some of these spine surgeries for spinal cord stimulation, even after ACDFs for spinal cord stimulation. And that has been really effective. Looking at our BURST DR Sunburst trial, about 80% of patients see up to 50% reduction in their pain after that particular therapy, and the outcomes are improving every few years in spinal cord stimulation.
And I think that's a totally different talk, isn't it? I mean, we should be able to cover later on. And have you encountered migration? For example, you have shown a fantastic one where you put a DRG stimulator at L3 level. Have you seen migration of those, or is it at risk? Is there a risk for that?
There is a risk, and I have seen migration. In fact, I've had 2 migrations probably. I don't know. I think I've done about 100 DRGs in the last 4 years. It happens. And we have a discussion about whether we should be anchoring these leads and doing something more. But the risk there is that the anchors may cause the lead to fracture at the point of the anchor. So even right now, we are having a large discussion about anchoring the DRG leads, and we're looking at doing that. What's interesting with the peripheral nerve systems, as you saw, many of them have the tined leads. We couldn't do tined leads in the epidural space because then we would never be able to get it out. But in the periphery, we can do that because we could cut down, and if we had to remove it, we could remove it. So these tined systems are very interesting. It is my opinion, I think we're over tining. I think we're putting so many tines, it's impossible to take it out until you cut down. So I think we have to find the right balance. But migration is a risk. We continue to work on reducing it and just finding it to a point where at least we can reverse it. We can do both, then great.
Thank you, Ramo. I think that's all the questions that we have for the session. Thank you, Ramo, for this fantastic lecture. And I'm sure this lecture is going to benefit a lot of people all over the world. Thank you so much for joining in.
Thank you so much, Hitesh, and take care. Have a great day.
Bye.